before we get too far into content, I just want to talk a little bit about how do we take care of ourselves. So I talk about that a little bit. First of all, I think I've asked this a different time. What is the resource CCRI has that's available, I think 24 hours a day, that you could reach out for mental health help? All right. Okay. So during our first break today, we'll have an extra long break, and the first 5 minutes are you to pull this information up. My SSP. Okay. So the before you take your first break, you have to find out from CCRI. You type in CCRI My SSP in your search bar, it will pop up. At least you'll be familiar with, if life is coming down on you hard, where can I reach? Okay. But sometimes life is just stressful and it's not like a crisis. It's just something we need to manage. So how many people have done a really good job on a class for 14 weeks, but then all of a sudden week 15 finals week comes along and you've just had it? You can't find enough power to enough strength to study that extra hour. You wanted to get, if you got an 85 on your final exam, you're going to secure the A for the course, but I'm just going to take it and I'll be okay if I get a B. Like, how many people have been there? I know I have. So I think the reason for that is not only final exams are tough, like that week. I just talked about how I like to spread out exams to make things a little bit more manageable. The final week is the final week. Everybody's got the last week, and our grades, class ends this day, grades are due the next day. Like it's a hard date. So we can't spread things out. So that's part of the challenge. I also think that's also a reason because we didn't take care of ourselves appropriately in the first 14 weeks. I think it's a fatigue problem that's cumulative of the semester, not necessarily just the final week is hard. So I want you to think about yourself, and it's been, what do we say, somewhere between 3 and 9 weeks that we've been here together. Over the last 5 weeks, I think it's week 5, 6, 5. Over the last over a month, how have you done taking care of yourself? First of all, let's think, how do we take care of ourselves? Give me some examples of how we take care of ourselves. There's an infinite number, but sleep, I think, is the number one thing that we need. There's truckloads of hard data out there to say how important sleep is. You know how much sleep we should be getting as, but young adulthood, 25, 20, somewhere around 8 hours. Between 7 and 9 is what most research says, and there's some individual preferences. I think the better data says between 8 and 9 is the number. So, okay, think about yourself. How many people are getting 8 to 9 hours of sleep? Right, a lot of no's. So that's something we can try to improve upon. And sometimes life is really hard. I get my most work done after my kids and wife go to sleep. At 9 p.m. is when my work day starts sometimes. So when I have to come up with case questions, it's going to be at 9:30 at night. And then I'm going to work on that for an hour or two. And then if I really get in a groove, it's way later. Oh my God, it's past midnight and I got to go to bed. My alarm clocks, named Scarlett and Nash, wake up at the same time every single day, and they don't have snooze buttons. Right. So I can't say, yeah, I work till 2 in the morning, but I get to sleep until noon the next day. Now, I don't have that luxury. I know some people in here also don't. If you have work or class the next day, yeah, you got to show up. Right. So being dedicated to our sleep can be really beneficial. And even if you're averaging 4 hours of sleep, how can we make it 5 hours? Let's make it realistic. Like going from 4 to 8, Realistically, probably not going to happen. But if we could get in 5, then that would be a big benefit. And that's the same thing we would say to our patients. You're not exercising at all. Going from nothing to walking 3 minutes a day would be huge. And then from 3 minutes, maybe we build up to 5. And maybe we build up, right? So yeah. Perfect. Absolutely. And part of the goals within physical therapy and all behavior changes, they should be realistic to get somebody from, and I think you probably have the most personal experience with this. How do you make huge lifestyle changes? You can't do it all at once, you know. Yeah. 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 What a victory if you're able to do that and be consistent with it. Absolutely. Yeah. So if sleep is the thing for you that you're cutting out, and I think as young adults and I think as students, it's the easiest to cut out because the next day you're okay. The younger you are, the better you are. I know for me, there was a time in my life 4 hours a day would be nothing. Be partying all night, go to. I remember very late nights, uh, all sorts of shenanigans, and then waking up at 8 a.m. and playing basketball for 2 hours the next day. Like, there's no way any of that would happen now. So how can you make sure you're taking care of yourself? Because it might not damage you tomorrow, but I think the cumulative effects of 3+ months, and then all of a sudden it's final week and you have that extra bit of pressure, I think things can start crumbling because of that. Yeah. Absolutely. Yeah. 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 And that's exactly what I mean about that final week, looking at your grades and going, you know what, I'm just done. I know I'm gonna pass. I'll be all right. So sleep, I think, is one way we can take care of ourselves that is easy to cut out. It's easy to be one of the first things. What's some other ways we take care of ourselves? That's nutrition and exercise, I think, are the two other big things. So as we're studying, what are we doing nutritionally as we study? What are we eating? Whatever crap is around. It comes in some sort of bag or bottle. Like, there's nothing. Anybody study while they're eating carrots? Yeah, Lexi says, yeah, me. All right, so if you study group, Lexi's gonna create the vegetable platter for, which is great. That's fantastic. You're the first person I've ever talked to say that. Most of us were eating candy bars, something sugary, energy drink. Like that part is the problem. So it takes a little bit of planning, just a little bit of head thought to say, like, what am I going to have on hand that's pretty good for me that I can use while I'm studying? And I know we're all busy. Making a good meal does take time and effort. So it's easy to be like, oh, God, I'm so busy. I'm just going to go grab fill in the blank. But taking that little extra time to have something more nutritious, it pays dividends. Exercise was the other one you want to talk about. What's the easiest thing to cut out on a busy day? Exercise, right? I got to work, I got to study, I got to do this, I got to do that. I got to learn about how to exercise. I'm not actually going to exercise myself. And I think that happens all the time as students. There's so much that exercise does for us that's good for us, better for brain chemistry, good for physical health, better for the aches and pains when I chain you to the chairs for 2 days all day long. So there's so much benefit that happens with exercise, not only physically, but emotionally and mentally as well, that we should be incorporating it into our lives. Now, if we can't go rock climbing 3 hours a day because, you know, we just don't have the time to do that, but could you walk around the track, walk on a treadmill, ride a stationary bike as you're flipping through your notes? You know, not the intense level of studying where you're creating things and writing things and, like, you know, I said you have a brain bomb that goes off on your desk. You just got papers and drawings everywhere of all your studying, right? So you can't do that and you know, ride a bike. But could you watch a video of a lecture? Could you do something else as you're? Could you flip through flashcards or Quizlets while you're walking around on a track, right? So how can you incorporate exercise even at low levels into your day? I think we all can find some time, even as little as 20 minutes broken up to 10-minute segments of walking is enough to have some good benefits. So, you know, sleep, nutrition, and exercise. Any other ways we take care of ourselves?
Maybe just your brain, like time management. Like sometimes what we do throughout the day is bad. It's timing and the sequence of it that you have to.
Yeah.
Modify.
Yeah.
I know that.
I think having good time management is a way to fit all of this in. You can do it. I think we have to become more efficient with our time. And if you want to talk about how to become more efficient in the time, you can definitely talk to me. The academic coaches at the tutoring center are really good at that as well.
We can take you had a point earlier too about like, you gotta, you know, do something that you enjoy doing. Well, it can't be all like just what you have to do.
So that was the next thing I was hoping we would talk about is what are the things that brings you joy in life that's different than having to do something. You know, I said rock climbing already. Who likes going to concerts? How about going out with friends? Right? How about drawing, art, painting, you know? How about my nephew's really into airsoft. Anybody like paintball and airsoft? Smashing things, shooting things, right? So what things do you enjoy? And let's have good time management so we can still do that stuff. Joy and laughter does things for your brain chemistry. We'll look at that more next semester, but adding joy and laughter to your world is really important. So how do you do that? It could be as simple as watching a comedy special on Netflix. That, like, the act of laughter and joy does tremendous things for stress management. And I hope you know what you like to do and you can find ways to add that to your life. Yeah. Yeah.
And based on their entire treatment plan around the lake, we have mini portable boards.
Yep.
And we'll have them do it like balance screen, they're actually playing against each other. Have them do like balloon tosses.
Yeah.
Sitting up to the boards. She's really working on trying to incorporate fun.
Absolutely. A quick deviation from our conversation. I think most of our physical therapy treatments can be done with having more fun. It's easier to just say, well, here's the band, here's the weight, do this, and that's good. But I think the next layer I would hope we all get as professionals is we get to have more fun, because with pediatrics, can you get your 8-year-olds with knee pain to do straight leg raises 3 sets of 10? Good luck. If you do, great, but it's not going to happen. So what do we have to do to get kids to participate in PT? It has to be fun. It has to be fun somehow. So the pediatric therapists of the world do this. That's just what they do. I think when we talk about adults, I think we become way less creative and way more rigid. And I think if we were more creative, our no-show rates would plummet, our cancel rates would plummet. I think our patients would be more involved. And I think when we talk about lifestyle change, how we can show that exercise can be fun and it doesn't have to be this, I think we could get more people making bigger lifestyle change. We can open up some ideas and some minds. But yes, having more fun in life. Yeah.
Only because the also I can't constantly be faced with the battles that I know that I'm going to be coming against or going against every single day. So if I know that going home is going to be I'm not talking about like throwing stuff, like on television, but if I know that going home is going to be chaotic because I have to attend to the kids or do something, knowing that I have support in that area, I'm going to go to like the library or stay here, or be in the park, go to the park, go study, or just somewhere where I don't face so many multiple problems. you know?
Yeah.
It's not home, but I have support of people saying I could watch the kid or I could be a little bit this way for you. I'm gonna take that and I'm gonna go off with it.
Yeah, that's a great thing. I think a lot of people have trouble asking for help. We're taught a lot in our life in a lot of different ways. Like you just got to do it. How many of us know that nutrition needs to be improved over the last month or so? How many people that are nodding either, out loud to me or in your own head? How many people know someone that if you called them up, my godmother, Barbara, if I called her up and I'd say, hey, Barb, I have a student, Abby, and he said that his nutrition has taken a dip in the last 4 weeks and he just can't find the time to make himself a good meal. You know what my godmother, Barbara, would do? Make him 3 good meals and say, call me in a week or two and I'll have you some more, right? How many of us have someone like that in our life that would be like, oh, that's all you need? Done, right? So asking for help on some of these things, I think is really important, whether it's to take a responsibility for us for a little while or to give us something like a meal. So, the analogy that I had a friend who's a counselor, he talked about it and he said, like, if we think of everything like a video game life meter, like you're playing Mortal Kombat and we got a life meter and there are things, punches and kicks that drain our life meter. But different from a video game, we get to also add to our life meter. Good exercise, good sleep, good nutrition, having joy in our life all adds to our life meter. And if all you're doing is stressing about school, and I know it's stressful, and all you're doing with your time is work and school, and I know there's bills to be paid, right? So, and I know there's kids to take care of, and I know all of that. But if all you're doing is getting those little punches and kicks every single day, at the end of the 15 weeks, that life meter is when the actual stress on work and the final exams, that life meter doesn't have any more to go. So add to your life meter. Don't just take away from it. Okay. All right. No, that was a great discussion. Thank you for having it with me. If you want to talk more about it, I'm always available. My office is always open. If I'm not in this room, I'm in my office. And email is always open. So I've been talking too much. I want to just do one thing that's easy. We'll kind of jump around this PowerPoint a little bit. We're going to jump down to slide 22 if you're following along with something. Easy thing to talk about, respiratory rate. So we're going to talk mostly about vitals today. We'll probably get into some transfers later, but mostly vitals. Respiratory rate is one of them. We've already practiced the hands-on of blood pressure. This will be the next thing. This is one of the easier things. It's the number of breaths we take per minute. Norms for adults, 12 to 20 breaths per minute. Kids, a little bit faster than that. Infants, even faster than that. What does tachy mean? All right, you guys took med term. That was one of the words you had to learn. What does Brady mean? Slow. So tachypnea or tachypnea. I think the P is supposed to be silent, although that might be a tomato thing. High respiratory rate higher than the norm, 20 breaths per minute. And then Brady, slow, respiratory rate slower than 12 breaths per minute. So when we talk about heart rate and respiratory rate, most of us just think of the number of times per minute, but there's more information we want to gather. So we're going to be counting the number of breaths per minute. We're also going to be looking at the rhythm. So are the breaths regular or irregular? Irregular respiratory rate is pretty uncommon. Heart rate, it can be common. So are the breaths at the same point in and out? Right? Is it predictable, or are we right? Just like if we were to watch Rose let go of Jack and we start crying, right? That would be an irregular respiratory rate. And then the next thing we want to account for is the depth. Is it normal? The definition of normal respiratory is for depth is the rise and fall of the chest and abdomen is observable. Deep is obvious, and shallow is barely perceptible. Something I don't get into in this class, but it's something else that you can put in the back of your head. There are conditions and some specialty practices that you might want to know more about. Is the patient really breathing more of their thorax, lateral costals, diaphragmatic? There's a lot of things that you could add to that. I won't ask you to do that for this class, but it's something that you just put in the back of your mind. You will definitely learn it in PTA 3. But for now, let's just put that in the you could also category, not the hard and fast, the things we definitely need to know. So how are we going to assess it? One, make sure your patient is comfortable. Making sure our patients are comfortable with where we look. If my patient's female and I'm just staring like this, that's a recipe for the very least they're not going to show up next visit. That's probably the most minimal thing that'll happen to you. So making sure where we look, having a lateral view versus the straight on view is instantly more comfortable. Even though we're still assessing the chest and abdomen, it is less personal. It's less, I don't know if aggressive is the right word, but you know, that intimidating may be better. I don't know. What is it? Intrusive, less intrusive. That's probably a really good word for it. So making sure we understand where our position can be crucial for this. Now, the upper thorax, good area to look. Having our patients sit upright, having good posture is good. Sometimes sweatshirts can be in the way. We can potentially ask our patients to remove that. Another easy way to do that, if I can't see, so if we look at Abby right here, it's got a sweatshirt on. Depth, give me a quick depth. Normal, deep, or shallow? Yeah, thanks for messing up. Probably shallow, right? Anybody just can't quite see it? I know we're far away. It can be really hard to see. If it's really hard to see, not only if we asked him to take his sweatshirt off or sit upright, if we laid him flat, that can help us, because then we can see the diaphragm and the kind of it working against gravity a little bit better. So sometimes changing our patient position completely can help. So one thing I will say, and this will make more sense after we do heart rate, but doing this at the same time as we assess a heart rate can be really beneficial because it makes the patient a little bit more comfortable. I like, if I can, my patient not knowing what I'm doing. Because if I tell everyone right here, we're going to start assessing posture, what is everybody immediately going to do? Right. So, and that's okay, you know, but so if I'm telling someone I'm going to assess their respiratory rate, they might alter it a little bit. So it's a question you just have to ask for yourself, right? Part of the art of the physical therapy is respiratory rate. Do you think somebody's going to modify it drastically? Not really, right? So I would rather have imperfect data, but a comfortable patient. So if I felt like, excuse me, young ma'am, I'm going to have to assess your respiratory rate right now. I'm going to be looking at the rise and fall of your thorax, and that's going to last for 30 seconds. I would rather tell that to my patient, making sure my patient understands what we have to do, and then probably asking, is that okay with you, right? Getting the consent to do that. I would rather have that happen with slightly imperfect data than have perfect data and a patient that doesn't show up next time because they thought I was too, what did you say? Intrusive. So again, part of the art for us. So what we're going to do is we're going to look at the thorax, count how many times the chest rises and falls for 30 seconds. Longer if there's something abnormal that's happening, that you can always go more. And then we're going to be documenting the number of breaths per minute, the rhythm and depth. So let's try that right now. Let's try making, tell our patients what we're going to do. Once we practice heart rate, we'll kind of combine them. But let's say, okay, Abby, I'm going to assess your respiratory rate right now. I'm going to stand right here. Sometimes it's okay to palpate as well. Sometimes you'll be able to feel where you can't see. So you might be able to do that. And then we're just going to count. Now, part of the skill here too is aligning yourself with what you're going to be using for your time. I can't assess appropriately if I'm doing this, right? So whatever you're going to use for your timer, make sure it's in line with your patient. All right, so try it seated, try it supine, see if there's a big difference. Doing it for 30 seconds, multiplying by 2. Do not forget, number one mistake of respiratory rate assessment for either comps or for practicals is forgetting to do the rhythm and depth. Make sure we're doing that as well. Okay? All right, couple of minutes on reps. Any issues with that? Would you guys think seeing the patient in supine versus seated? A lot easier, right? A lot easier to see. Any patients you wouldn't want to put supine to do that? Problem breathing when they're laying flat. There's a certain word on the next slide we'll look at. Yep. Good. Any other patients you think? That's the number one. What's that? I think if we were taking a diagnosis out of it, where the mobility it's required to get up on a table and lie down is so taxing that you'd say, I'd rather get bad data sitting versus perfect data supine. Potentially if there's other vitals issues like blood pressure, but I just think in the general, again, art versus science. Art says if it's going to be so taxing, get my patient up on the table just so I can do a vitals breathing check, a respiratory rate assessment. What else am I going to do? If I've only got a patient for 30 minutes, you guys that are techs, you guys have seen how long some patients take to get up on a table, right? So if you've only got 30 minutes, how much time does that patient take to just get up on the table? Good, solid 5 minutes. Yeah, I'm not sure I'm going to be, I think I'd rather get the imperfect data seated. And if I need, if I'm going to make that decision as a clinician, where would I document that? If I look and I say, I think I got 14 breaths per minute, but it could have been wrong just because I couldn't quite see it, but I elected not to put them in what? Assessment, in the assessment section. Absolutely. Good. All right, so common respiratory difficulties: dyspnea, difficulty or uncomfortable breathing, orthopnea or orthonia, I think is. You think what? Yeah, there's a P there. What are silent letters? I say I'm not, that's a letter there. I'm gonna be proud to be there, man. I'm gonna say what you sound like. So that's difficulty while laying flat. So if my patients do have difficulty laying flat, then that is something that we would stay away from. And actually, there is a measure. How many pillows underneath the head does the patient need to sleep with? That's one of the things in the home care environment I get to actually see. Oh, that's where you sleep? You got 5 pillows there. I think we got some breathing difficulties here, right? Because they can't lay flat and breathe at the same time. Paroxysmal nocturnal dyspnea, sudden episodes of dyspnea or orthopnea typically occurs at the same time every night. That's pretty crazy. And then apnea, absence of breathing. Probably not a good thing. There's one scenario I can think it's a good thing. Anybody know what that scenario is? Hey, if you're underwater, yeah. Yeah. Other than that, I'm pretty sure we're in trouble. So I passed around the pulse oximeters. Pulse oximeters look like that. All we're doing is measuring how much oxygen is bound to the arterial blood. We want to make sure we document for us SpO2. That's saying that we're using pulse oximetry. There is SaO2, but those are devices implanted into the arteries itself. That's where there's, a line coming out of the patient. So that's more of the hospital type setting. So that would be documented SaO2. That's a direct measurement. This is an indirect measurement. So norm is between 95 and 99%. In general, is unsafe to exercise below 90%. With some rare exceptions to that, there are some patients that I'll have their cardiologist write can exercise at 88%. Some, rare exceptions. Textbook for us, general population, written exam in this class, licensure exam, your rule is 90%. There's no 100% rules in the world, right? So put that in the back of your brain. So oxygen carried in the blood with dissolved in arterial plasma, 97% are bound to hemoglobin, which is the protein in red blood cells that binds to oxygen. So normal hemoglobin levels for males, 13.5 to 17.5. For females, 12.0 to 15.5. So it is possible to have okay pulse ox, but insufficient hemoglobin, which would make it unsafe to exercise. So that's part of the lab values. How does this all fit together? So again, sit next to Brent for the exams. You'll be all right. You can have, so that's what I just said. You can have high SpO2, but low hemoglobin to make it unsafe to exercise. So we already played with it. I didn't even have to tell you how to do it. Clean the device, put it on the patient's finger, turn it on. If it's not reading, you probably have to clean the finger, maybe reposition, maybe choose a different finger, and then clean the device when you're done. It's as simple as it could be. Now, some displays, I don't know if this one does it or not. This is a new one for me. Let's see. All right, this one doesn't do it. I don't know if those do it. Some displays will invert. It reads SpO2 and heart rate. Some of them will invert. The screen will shift depending on which angle it's held. This one doesn't do it. I don't know if those do or not. So just make sure you are reading what you're supposed to be reading. You don't want to be reading 79. When really that's their heart rate. So just make sure you know what you're reading. It should work through nail polish. It might not, but it should. I haven't had a problem with nail polish, but dirt and grime, those are the things that it does limit. But it might not. Do you have your nails on still? No. Anybody else have nails or nail polish, thick nail polish? Nothing? No. Got to take it off too. All right. So any questions with heart rate or SpO2? SpO2 is just kind of free. Yeah. I'm sorry, respiratory rate. We didn't do heart rate. Boy, that's a great question. I don't have a great answer to that. We're going to go back and learn heart rate. In general, I start with blood pressure and then heart rate. And I do my respiratory rate at the conclusion of my heart rate assessment. That's my general. And then SpO2. Actually, SpO2, I put on the right hand as I start working on the left hand for blood pressure and heart rate. So I don't have a perfect answer for that, but that's in general how I do it. My cardiopulmonary instructor in grad school made us do blood pressure, heart rate, and respiratory rate all at the same time, and we had to be completed in under a minute. We had to do it all at the exact same time. I don't think that was a valuable skill for me to panic about for those few weeks that I did it. But you know, she could. Anybody here play the drums? Drummers could do that well because they can count you can count multiple things at once. Everybody else was like, how do we count respiratory rates and heart rate at the same time? There's two different numbers and I can't do that. So anyway, maybe you want to try that. There's the Lexi look for me. Yeah. Yeah, that's right. That's right. You're scheduled for 30 minutes. I'm going to see if I can get you out of here in 12. All right. So vitals, also known as cardinal signs. So sometimes in textbooks or maybe in written exams, you'll see cardinal signs. We're not talking about fancy birds. We're talking about the vitals. So the cardinal signs include pain, temperature, heart rate, blood pressure, respiratory rate. Pulse oximetry is important, but not considered a vital sign. We lump it in with our vital signs, but again, technically speaking, it is not a vital sign. So why is it important? One, indication of overall health. That's one thing. And we might be some of the first people, we might be some of the first healthcare practitioners that a patient might see. Especially for our younger male population, where we skip physicals, maybe we haven't seen any for a while, that those people are walking around doing okay with the world, but spraining their ankle. We might be the first medical provider they've seen in years. So assessing their vitals might be a way to get them headed in a direction of improved health or identifying underlying conditions. Again, we're just seeing warning signs. We're not telling somebody you have this condition. That's not part of our role, whether it's PTA or PT, but identifying the abnormal values and steering that direction into in a place that they can get some help is. It also provides a baseline for patient and therapists. Not only if the norms are if their results are within normal ranges, but also gives some patient specific data. With my patients with COPD and maybe heart failure, like those are conditions that aren't going to magically resolve, but we can improve their function while we're working with them. If my patient can walk 20 feet and needs to take a break for 30 seconds after walking 20 feet on day 1, week 3, they can walk 20 feet, but still need a rest break after that 20 feet. But if their SpO2 initially on day 1 fell to 88%, but now it's staying at 92%, that is a sign of progress. It's small, but it's there, right? So it sometimes vitals can give us some data just to show how good we're doing. But I think the big thing is safety of exercise. Can we start exercising today? Or as we're exercising, this vital went to here, this number, and now we have to stop. We have to at least take a break. I don't know if we're done for today, but for right now, we need to take a rest. So that's probably the number one reason we're going to be using our vitals. We're also use our heart rate we can use to prescribe exercise and make sure the exercise is intense enough, just like we did it with our MMT score. Here's what your MMT score, here's what the exercise prescription would be, if we were to have it in a textbook. Other signs, patient observation clues that can give us information about vital signs. If we have cyanosis, that's that blue lips, fingers maybe, ears potentially, that indicates lower oxygen. If Rose had a pulse oximeter, she could have slapped it on Jack's finger and measured, say, wow, you're not doing great right now. Diaphoresis, profuse sweating. That's a sign that the body's compensating for some sort of reduced cardiac output, often a sign for myocardial infarction. What's an MI? Heart attack, hypotension, or shock. Abnormal posture might be interfering with breathing, right? Everybody kind of slouch down, take a deep breath. All right, now everybody have good posture, take a deep breath. Which one feels better? Which one's easier? So for my patients with respiratory conditions that I can't improve upon, I can't improve upon lung cancer, I can't improve upon emphysema. I hope to improve upon physical function, but I can't improve upon that. If I just improve posture by 20%, that's going to improve their respiration just because we're taking away that problem from it. We can look at accessory muscles use, which indicates cardiac and or pulmonary impairments. What are accessory muscles of breathing? What are our primary muscles of breathing? Diaphragm is the big one. Intercostal muscles are the next ones. What are our accessory muscles of breathing? Scalenes is an easy one to see. SCMs, upper traps, serratus anterior. Anybody ever use serratus anterior to help them breathe? I do. At jujitsu, it's funny, I can do jujitsu for hours on end, but the 3 laps we run around the mat as a warm-up are the things I can't do. So what do I look like after those 3 laps? What position am I in? There we go. So I'm why do we put, when we're exhausted, why do we put our hands on our knees or on a table? Reverse muscle action of the scapular muscles, the serratus. So I'm locking down my scapula. And now instead of the serratus holding on to the ribs and pulling the scapula along, I'm holding the scapula still, and the serratus is pulling on those ribs to expand them. Pretty cool, right? Same thing, upper trap scale is what we're using. So looking and seeing those accessory muscle use is another sign for us to take in. Presence of edema, indicative of right-sided heart failure or venous insufficiency. Clubbing of distal fingers. You guys know what is clubbing of distal fingers or toes? That's not like listening to DJ music. What are we? You like that one? What is it, Rachel? Let's give it to Rachel for keeping us on track. Like, all right, Josh, stop. So it's I'll pull up a picture of it. It is if we think of a golf club is a good one, right? It's real skinny, then gets fat at the end. That's basically what the clubbing of the fingers looks like. It looks like a normal finger, and then all of a sudden at the end, it just looks like a little bulb. So long-standing hypoxia or low oxygen. So pain, we already know. Consider the 5th vital sign. Pain belongs in subjective section of the SOAP note. Talked about some reasons why. Give me some quick reasons why. Because it's coming from the patient. It's coming from their mouth. It's not something we can measure directly. We have to take an indirect measurement of it. And what are some other reasons it goes in subjective? Because it's not as reliable as some of the other tests we have. Some patients are perfectly reliable with it. Others, work in an outpatient clinic today. How's everybody's pain today? It does depend on who we ask, but in general, today is going to be 75 blue skies, everybody's gonna be feeling pretty good. Last weekend when it rained all weekend, was it Friday it rained all day Friday? Anybody work on a clinic on Friday? How did everybody feel? Awful, awful, right? So things influence pain that aren't part of what we have to deal with. So that's another reason why we put it in subjective, just because it's not a hard and fast measure. It's not something we might be direct. Can we affect the weather? I try to learn rain dances when I can, but it's my timing is off, I think. So yeah, it belongs in the subjective section. So again, the minimum level we'd already talked about today. Some sort of rating, exact location, the best we possibly can. And sometimes being vague with our location is the exact location. It just hurts all around the knee, right? So that's the information that I do need. If they can pinpoint at patella tendon, great. I love that information. But even saying, no, it's just the whole knee just is there. Great. That's what I want. And I'll put in quotes, whole knee, and we'll make sure that the next therapist knows that. So exact location as best we can, and then with what function. Seated versus stairs is a big difference. When we talked about the 3 different most common ways we can use that numerical rating scale, 0 to 10. Number one, 2 mistakes I have for this. Number one, when we talk about our patients, anybody mistake and say on a 1 to 10 scale? Why is that such a problem for us? Because 0 is no pain. If we tell them a 1 to 10, we're giving them pain. You always have to be in pain. How many choices does this give? This is the written exam error. How many choices does that give the patient? 11 choices. So that's a silly written exam one. The visual analog scale, the 10 centimeter line, or the FACES Wong-Baker scale. Body temperature, we're going to talk about, but we're not going to measure it. Not frequently measured in PT, but it is very important when we talk or when we're concerned of infection. If my patients call me and say, hey, Josh, I'm wondering if, on the phone, I say, well, have you taken your temperature, right? And if I'm at the patient, I'll say, let's take your temperature. In the clinic, I have some sort of tool available to say, let's take your temperature. So that is the one of the best objective signs for when we're worried about an infection. So quick thought on signs versus symptoms. I think oftentimes when we read them in chart, they're lumped together. Signs and symptoms include, not only in textbooks, but also in charts. They are 2 different things. A sign is something observable to someone else. It can be measured, it can be seen. A symptom is something that the patient experiences. Pain, is pain a sign or a symptom? Technically, it's a symptom, right? Because even though I hope to measure it as best as I can't say, you have 30 liters of pain today. Like I don't have a tool that I can measure it. So that would be a symptom. So symptoms that the patient might experience, might feel. General malaise. What is general malaise? Just saying pain isn't a great way to describe it. You guys know the day before you get the flu, day before you get sick, you walk from your car to here and you'd be like, why am I out of breath today? Or like, it could be a nice day out and you'd be like, I just want to stay in my sweatpants today. I don't really want to do anything. You go upstairs and you go like, why am I out of breath? You know that feeling? That's general malaise. Not quite right. Like I'm just feeling off. I'm not sick, but I'm just off. That's general malaise. Headache, loss of appetite, restlessness, and chills are all examples of symptoms. Signs, observable, sometimes measurable. So increased pulse or respiratory rate, piloerection, hairs sticking up. Shivering, irritability. When we talk about irritability in the medical context, most of the time it talks about nervous system irritability, not you know, hey, don't talk about the weather with Nancy. She gets upset about it, right? No, it's not a attitude thing. It's a nervous system thing. Anybody ever, when they're sick, the sheets can't, the lights have to be off. Everything's too loud. The sheets get the sheets off me. I can't stand that sensation. That's nervous system irritability. Other signs: sweating, weakness, disorientation, confusion, convulsions, and coma all indicate a very high fever. Real big problem there. Could be other things, but something else when exercising in hot weather, heat can dissipate with either radiation, conduction, convection, or evaporation. So radiation, heat being transferred to an object through the air, conduction from one object to another via direct contact, movement of air or water, or sweating when turning liquid to vapor. So we can, if we are seeing our patients and we take their temperature, and when they're exercising in hot temperature, we want to cool them down. This is some of the ways we can do that. Move them to a cooler room, put an ice pack on them, direct contact, movement of air or water, get that towel, start waving it at them, and then hopefully they can still sweat. So measuring temperature, a lot of different devices, a lot of different pros and cons to the devices. Make sure you know what the device is, measurement errors, speed of reading, a whole bunch of different ways to, if you have kids, you know of a bunch of ways to measure temperature with their own pluses and minuses. I think my favorite is it's called Tempadot. You guys ever having a fish tank? You know, the little stickers on the side that tells you the temperature of water, they have them for, you could put a sticker on somebody's forehead, and that's my favorite one. I've never seen it clinically, but it's always something to be like, all right, I hope somebody has a fever today. I want to put a sticker on them. And anyway, let's talk about heart rate. Heart rate, just like with respiratory rate, we're going to measure not only the number of beats per minute, abbreviated BPM. We're also going to look at the rhythm, and then also the force. So instead of depth, we call it force. So rhythm is what is the pattern of contraction? Now, an irregular rhythm is much more common in the heart than it is for breathing. So, and some of us here might have irregular rhythms. There are rhythms that are irregular. Every fourth beat, I'm going to get a double beat. And sometimes there are irregular, where it's kind of all over the map. It's not up for us to know which one is which. All it's up for us to know is this is an irregular heartbeat. Let me talk to, if you had a patient with an irregular heartbeat, what would your steps be? Bring him in. Hey, Larry, how you doing? All right, let's try with the vitals. Hey, did you know you have an irregular heartbeat? What would your next steps be? Maybe asking them, do you have any history? Do you have a cardiologist? Yep. Next step. Let's get, yeah. Yeah.
I'm gonna make sure that they're comfortable, they're fine.
Yeah, some water. Yeah, are you comfortable? So, boy, that's a great, I think that's actually a perfect answer, because I didn't give all the information. If they have an irregular heartbeat and they also have excessive sweating, even though it's not all that hot out, boy, that's a different scenario than if they're any of us right here. We might have an irregular heartbeat, right, with no other signs or symptoms. So if they had other signs and symptoms, what would you then do? Irregular heartbeat, patient says, I feel like I've got heartburn, and you think they're sweating excessively. Yeah, it's warm outside, but you're kind of sweating a lot here. What would you then do?
Well, consistent of like, is there more to go? What's going on?
Yeah, all right. Any have a different question? I would think we're having a hard, I think, yeah, having a conversation is okay. I think the conversation would be, I'm going to call 911 right now. What else happened with you today? yeah, my next step, if there's additional signs and symptoms, yeah, I would say it's 911 time. If the additional information was patient's fine, no other problems, you just found an irregular heartbeat, what would your next step then be?
Well, the patient's fine.
No, everything else is great.
Obviously, wait a little bit, and then you gotta check your vital, and if he doesn't meet these criteria.
Okay.
You can't go along with it.
Okay. So maybe wait a little bit, check it again. Yeah, okay. Yeah, maybe it was our error. Yeah. Let's say it's not. I think your next step is probably contacting the PT. And maybe the PT knows, oh yeah, we know that he's got an irregular heartbeat. Okay. That's we get to collaborate with the PT on what to do then. Okay. All right. And then the force is basically how easy is it to palpate? It's an indirect method for how strong is the left ventricle. So norms, adults, 60 to 100 beats per minute. Kids a little faster than that. Newborns even faster than that. Rhythm is either irregular or regular. And then force, we're going to have a 0 to 4+ scale. 3+ is normal, 2+ is weak, 1+ is barely perceptible, fades in and out. In here, we're going to feel thready pulses, but that's going to be because of our technical error and our skill. It's not going to be because of our classmates, I hope. 0 is nothing, not feeling anything. I know I'm doing a good job and I'm not feeling anything. What would that probably indicate? It's 2 major problems, but. Probably not venous return, some sort of artery. So if the patient is talking to us, there's probably some sort of blood clot blocking that. So big, serious problem. Or, I mean, they're probably, if it's from the heart, they're probably not talking to us as we do that. And 4+ is bounding, very strong, cannot completely obliterate the artery. Sometimes that's going to be okay if we just sprinted a bunch of laps, then that's okay. If it's just at rest, wow, this heart's really kind of going haywire all too much. So stroke volume is the amount of blood ejected from the left ventricle for each contraction, and cardiac output, abbreviated CO, is how much blood is pumped per minute. So cardiac output is your stroke volume times your heart rate. And that tells you how much blood is circulating per minute. Adults should circulate between 5 and 6 liters of blood per minute. If we had low heart rate and we couldn't increase it, the body rate, because when we do more activity, the heart rate should increase because we need more circulation. That indicate a problem. Sometimes a stroke volume is low and the body compensates with a higher heart rate. That's how those are intertwined. All right, so we've already palpated one of them. Which one did we already palpate? Which location? Brachial artery. All right, so before we go into this, let's palpate the brachial artery. We want to do it for 30 seconds. While noting this time, we're going to note the rhythm and force as well. Okay, so let's just start there, and then we'll learn some other locations we'll have to worry about. Do it on someone else, okay? So there are other locations we could use. If a patient doesn't have arms, we can't use brachial artery, right? So we do have other options for us. For kids, the easiest is using a stethoscope over their apex of their heart. That's typically the easiest for kids because we can hear it. They're not moving around. They're not complaining about anything, I think our force for the smaller limbs can be too excessive too. So that's typically the easiest to do it. Other sites we could use temporal only when other sites are inaccessible. That's a really odd one to use. We could use carotid. Not commonly used for us. How many people love their throat being pressed into by other people? Right? Excuse me, I understand you have terrible anxiety. I'm gonna put my hands around your throat for a few minutes. Yeah, yeah. Well, in a case of shock, it's easily accessible, it's strong, right? So it is easy for that. A couple reasons why we don't use it in physical therapy, other than the patient feeling of it. We used to be worried if they have peripheral artery disease. We used to think that if you have poor skill in finding it, this searching method can break off a plaque and cause the blood clot somewhere else. That doesn't really happen. That was one of those things that we were afraid of 40 years ago that never really went away. But what does happen, there's a bunch of receptors in your carotid and jugular that control blood pressure. And if that massaging, I shouldn't say massaging technique, but the palpation technique where you're trying to find it could stimulate those baroreceptors and alter the blood pressure. So if we're, and also heart rate because of that. So if we do stimulate that, now we're directly impacting the measurement we're trying to get. So we don't like to use it for that reason. There might be some textbooks, and I hope not exam questions about that plaque breaking off thing, but that is, if you talk to older clinicians, they would say, oh, you can't do that because all right, that doesn't really happen, but okay. So we won't have to worry about that. Brachial we just did. Radial is next. Midline of the radius. Again, the radius, so we should all know where the radius is. Right at midline. One of the techniques I have for palpation is having a bigger search party when I can. I won't always be able to, but making sure I'm on the pads of my fingers helps my cover more surface area. That way, if I say, oh, I got to roll a little bit this way, roll a little bit that way, using as much surface area of the pads of your fingers. But especially on the bigger wrists, using 3 fingers instead of 2 might be beneficial for you. And you guys remember when some people had to push away the biceps tendon to get underneath it? You might have to kind of get underneath some of these flexor tendons as well to get after it. So this is probably the most common site to use for just heart rate assessment. So let's practice on someone else the heart rate, and then I'll show you 2 a little bit more difficult ones. So grab somebody's radial pulse next. All right, I have 2 more locations we're going to practice, then we'll take a little break. Before we do these other locations, something important that I want to make sure we understand. Something called a pulse deficit. So if we were to measure with a stethoscope heart rate at the apex, the apical pulses and the peripheral pulses should be the same. If there's not, that's called a pulse deficit. That indicates some serious cardiovascular disease or peripheral vascular disease. And that means we stop everything and we send the patient to get a further evaluation done to determine how safe it is for this patient to participate in any level of exercise. So that's why understanding the apical pulses, it's not something we'll do right now, but understanding that if pulse deficit is a huge problem. And what do we always say? Anytime there's something that's a huge safety thing, what is your job? Star it. Yeah, it's important to know. All right, other locations. I'll do these next 2 locations. They are, I think, the hardest ones, especially this popliteal. So can I have your leg? Can you come up here? I'm going to show you prone first. Go ahead and face down. I'll show you 2 ways to do it, and I prefer the prone method, although, you know, I'm going to record from here. Is that okay there for you guys? Yeah. I'll show you this method, although some people supine just works better. And I mean by people like the clinician, but also the patient. Couldn't tell you exactly. So the popliteal pulse is just lateral to midline of the popliteal space. Now, anytime we want to palpate something, what should we do to that tissue? Just broadly speaking. We don't want it to be contracted, right? Anybody ever try to palpate the brachial artery when somebody's contracting their biceps? Way harder, right? How about if we're all the way extended? Way harder, because now that tissue is taut and palpating through that tissue is a lot more difficult, right? So we want to make sure our patients are not contracting, but also not fully elongated. Whatever that tissue, whatever we want to try to do, right? So if we, in a second, I'll grab bolsters from the other room, but all we want to do here is we want to flex our patient's knee slightly, 30-ish degrees. It's just enough to get the tissue not as taut. We also want to have our patient have a bolster with it, because you guys can see how these hamstrings are contracting there. Relax, Abby. Relax. There we go. There, see how it disappeared, right? It's because I don't want to have to palpate through that. Oh, perfect. Thank you. So next thing, I want to go just lateral to midline. So there's two ways to do it. Get to just lateral to midline and palpate deep. Or the most likely thing I'm going to have to do is I'm going to have to move that popliteal tissue out of my way, just like we did this. It's the same technique we did with biceps before. So I want to appreciate his popliteal space. His midline is right here. And I'm going to go just lateral to midline. So I'm going to put kind of my fingertips right on that midline. And then I'm going to roll my pads to just lateral midline. And I'm going to press deep, because I want to palpate through all of his tissue. So I hope the video you can see, and I hope you guys can see too, like I'm using my pads and I'm reinforcing my hand here just because of my flimsy fingers that I've talked about before. If you've got solid structure, you don't have to reinforce, right? So start at midline, roll my pads just lateral to midline, and then I'm palpating with a good amount of force. You feel that force, Maddie? Painful at all? Okay. He's got a great popliteal pulse. So most people, it's going to be a lot harder to find. On those people that it's a little bit harder to find, especially if they have a lot of tissue here, what we're then going to do, feel it, and I'm patient, especially if somebody's got a low heart rate, right? Because if he's got 40 beats per minute of a heart rate, just in a great shape, good stroke output, low, I don't want to give up in between beats. I can't feel anything, right? So just wait. If I still can't feel anything, what I'm going to do is I'm going to lighten up some pressure. I'm going to slide to the border of the popliteal space, which is the hamstring tendons. I'm going to leave the hamstring tendons lateral. I'm going to go a little bit deep from there, and I'm going to push that tissue away. Did you see how that tissue kind of got pushed away? I don't think we'll see that. If you can't see it, get close. So again, I'll show my whole procedure. Fingertips right at midline. Roll so my pads are just lateral to midline. Deep pressure, be patient. All right, I feel like I've been patient. I still don't feel it. So what I have to do then, lighten up pressure, slide to the border of the popliteal space right when I feel that hamstring tendon, right? That's the rope-like tendon, should be pretty obvious. I'm going to give a little bit of pressure downward, and then I'm going to work my way just back to just lateral to midline. And you guys can see now how that tissue got out of my way. And now I'm going to go deep to there. And it should be more obvious. Errors with that is if we put too much pressure here as we go back to that just lateral to midline, now I'm potentially pushing that artery out of my way too. So there's a amount of force that you need to just practice with. So this can be frustrating. Abby's got a great one. There are people in here that have ones that are going to be really easy to palpate and others that are going to be really difficult to palpate. My suggestion to you is find someone easy and find someone that's hard, because that's how we get better. All right, flip on over. I want to show you the other version. And again, Some patient, I prefer this one because I can visually see what I'm doing. This one, I have to rely on my fingers to be my eyes, which is okay. We're developing eye fingers with all of your kinesiology, palpation, all the stuff we do in here. So that is okay. Bend the knee again, roughly 30 degrees. I'm going to have my hands. I'm going to appreciate his popliteal space. I'm going to put my tips of my fingers at midline, and I'm going to roll my pads to just lateral to midline and then press deep. Let's try that there. Be patient. Wait. Uh-oh, I can't feel it. I'm going to slide, lighten up my pressure, slide to the lateral border of the hamstring, and then push that tissue out of my way and then go back deep again. And again, I prefer the prone method because I can see everything with my real eyes. Some clinicians prefer this, and some patients, for some reason, you can just feel it better in this position than the prone. And I can't figure out why, but we'll try them both with someone that's hard, that's a difficult one to find, and someone that's easy, that's got an easy one. Okay. All right. Next one. Can you take your shoe and sock off? Is that okay too? Doing the top of the foot.
I have to.
You don't have to. Anybody have a foot they want to? Do you have? Is that okay? You've already got slippers on. Go ahead and sit up here. That's okay. All right. So dorsal pedis pulse is next. This is the one that I find the biggest variation between individuals. So I'll tell you how we're going to get there, and then you're just going to have to go searching for it. Again, anytime I'm concerned, if my hands fit, I use a bigger search party, more fingers than I can. So the dorsal pedis pulse is, if we're going to start between the first and second toe web space, we're going to come right up into the bone that sticks out. You guys know what bone that is? Navicular, good. So we're going to follow that line right up to the navicular, and I'm going to have a big search party, all 4 fingers, and I'm going to lay it with firm pressure. There's not a lot of tissue here like the popliteal space, so I don't have to be quite so aggressive. But I tell you what, I'm going to have to move proximally. I'm going to have to move distally. I'm going to have to move medially. I'm going to move laterally. There's the widest variation between people is going to be with this one. It's there, but start at first and second web space up to navicular. That's your starting point. And then start looking. Be patient, but start looking. Okay? All right, so we have 2 difficult ones to do. Let's spend some time practicing that. Thank you for the foot, Morgan. Thank you for the knee, Abby. Yeah. Put it on the Tinder profile. Likes, weakness. By the way, don't want to brag, but great popliteal artery. Started recording right before I said that sentence. Now it's completely out of context on the recording. That's one for HR. HR, we have on Josh, sit down here for a second. We have on video you talking about Tinder profiles and things. Yes, but well, who's the one that recorded this? Well, me, but well, you don't understand. All right, back to school for a second. The big reason why we're learning these different locations, there's 2 major ones. One, because if one of our locations is blocked, not arms, embedded IV lines or other things that block our ability. I have a patient who is really spastic. She has MS and she can't really extend her elbow all the way. So I can't palpate that. And it's difficult to get the radial. So I have other options. So it's always good to have other options because we do have unique patients. The other thing that is really helpful for is the ability to monitor circulation throughout the body. So I didn't have us palpate the femoral artery. We could, but when that's really going to be important is palpating the force of the femoral artery versus the popliteal versus the dorsal pedis. If the force is 3+ at the femoral, 2+ at the popliteal, and 1+ at the dorsal pedis, now I'm concerned of inadequate blood flow. So that's where I would put all of these things together. If the dorsal pedis, if I'm worried about geez, my patient has a lot of swelling, some redness today. I'm worried about blood clots. Palpating the dorsal pedis pulse is one way to say, like, okay, I'm still concerned, but I can feel this pulse. That's a good thing. So that's why these different locations can be really important. As we practiced with both the popliteal and dorsal pedis, how many people forgot to measure rhythm and force? Yep. Okay. So again, number one mistake of when we do this for both comps and practicals is forgetting to measure pulse and measure the rhythm and force. So after a break, we're going to come back and we're going to do that again. Next up, we have blood pressure. So we already did blood pressure. So what we're going to do is we're going to take a patient, we're going to measure all of the vitals that we just did in a nice cohesive, simple fashion that we'll get really good at. So let's take 20 minutes. But for the first 5 minutes, you have something to do. What is it? Find my SSP on CCRI, so at least you have it. So that's your first. If it takes you 5 minutes, then it shouldn't. So take a break, and then we'll do the rest. Sure, my sound works. Test, test. All right, good. So we're working. All right, so blood pressure norms, each agency, we'll call it, has slightly different guidelines as to exactly what falls in different categories. So the American Heart Association might be different than Red Cross, might be different than American Cardiothoracic Surgeons. So this is one of those where if you study outside of the material I'm giving you, we might start getting questions wrong on exams because you studied something that wasn't exactly what I was covering too. So what I want you to learn, and this is what it says, what we will use for exam testing is this slide here. The next slide, I have other norms for you that you can be aware of when you spend time in hospitals or with surgeons after cardiac surgery. You might have different guidelines to you, but for this class, what we're focusing on is normal blood pressure is between 90 over 60 up to 119 over 79. Hypotension, low blood pressure is lower than 90 over 60. Elevated 120 over 79 to 129 over 79. Stage 1 hypertension, 130 over 80 up to 139 over 89. And stage 2 hypertension, 140 over 190. So if on a question it says a bunch of information that you don't need, here's all the vitals. One of the vitals is blood pressure is 136 over 92. What is there? Let's make it easy, a little easier. That 136 over 82. Then you'd have to select stage 1. Or if the question was which one of these falls outside of normal ranges, you would say blood pressure. So here's a different classification just for your own resources. Again, different JNC7. I forget what that was, but slightly different. And while you might hear pre-hypertension versus hypertension, you know, the categories we're looking at, it's not considered pre-hypertension, considered elevated. So there might be some vernacular if you talk to other healthcare professionals about. That's where that comes from. So to assess, again, we've already gone over this. Make sure the patient's relaxed. Arm is at the level of the heart or in supine to be the best positions. I think we've done a really nice job with that. I won't have to go over this right now. But for documentation for all of our vitals, make sure we're attaching units to it. That's, I think, the easiest mistake to make in our documentation. So on our next SOAP note that we'll have due, that'll be one of the things I'll have to point to and say, well, you didn't include your units. So units for heart rate, BPM, beats per minute, respiratory rate, breaths per minute, blood pressure, mmHg, millimeters of mercury. We also want to make sure we include what patient position and which limb we're using. Blood pressure can decrease from going supine to standing. Obviously, orthostatic hypotension is something we're really worried about, which means the patient's at high risk for falls. So what I want to do right now is I just want to practice assessing a patient's vitals, blood pressure, heart rate, respiratory rate, and SpO2 all in a row, all combined, right? So, hey, nice to meet you. My name's whatever. I'm your SPTA. Can I get your confirmation name, date of birth? Great. First thing I'd like to do with you today is assess the vitals. Is that okay with you? Great. And then go into your all of these four. So I would assess blood pressure first. Then I would assess heart rate for 30 seconds. At the completion of my heart rate assessment for 30 seconds, right? I'm here. I do my 30 seconds for heart rate. What's the number one mistake after assessing heart rate? What's the one mistake that we've already made today? We're not going to make it again. Forgetting to assess rhythm and force. So I'm going to make sure I do that with that 30 seconds. My next 30 seconds, I'm in perfect position to assess respiratory rate. I'm just going to hold them exactly here for the next 30 seconds, and I'm going to assess their respiratory rate like that. That's probably the easiest way to assess all of those. And again, I have the pulse ox on the other hand as I do it. You do it at the end, it doesn't matter. When I think my patient might be uncomfortable is when I tell them I will also be assessing your heart rate, your respiratory rate as well. So try that out if you need to. If we can't get a good measures all in this position, what can we do? Move to supine. Move to supine. We can assess all of these in the supine position as well. All right, so let's spend, at this point, it should be pretty quick. Let's spend probably 10 or 15 getting those reps in, okay? So next thing we'll talk about is cardiovascular testing, exercise prescription, and then what happens with vitals. So first thing we need to figure out is what is our target heart rate for our patient? Because the great thing about cardiovascular exercise prescription is it's so mathematical and it's so easy to know if we need to change the exercise. So if our cardiovascular exercise is too easy, not intense enough, we're not going to get a cardiovascular benefit. We're not strengthening the heart. It might be good for other things. Walking at a leisurely pace is great for a whole host of reasons, but it's not getting the heart stronger. So if you have a patient with a heart condition, that is the goal, and we want to make sure our exercise is intense enough for that. Just like doing rows with a yellow TheraBand, if we're able to do 30 or 40 reps, is that going to help any of us with strength? It might be good for other reasons, but we're not going to become stronger with too light of a load, right? So that's the same thing for cardiovascular exercise. Typically, we want to exercise at between 60 and 80% of our max heart rate for 20 to 30 minutes. And we can take 2 to 3 weeks to progress to that point, but that's the exercise prescription for most people. 60 to 80% of max heart rate for 20 to 30 minutes. So how do we figure it out? Simple way. First, we figure out max heart rate, which is the simple formula is taking 220 and subtracting your age. So for a 20-year-old, what is their max heart rate? 200. And then we take that number, that max heart rate of a 20-year-old person, 200, and we're going to multiply that number by 60% and 80%. So who's got a brain on them today or a calculator on them today? What's 60% of 200 and what's 80%? Chad, you do 80%. Danica, you do 60.
Oh, 1,
All right, 20.
and then the 0.8 is
Max heart rate equals 220 minus, which is 20 equals 200 beats per minute. Target. What was 60% again? All right, everyone see how we did that? So now we throw our patient on a treadmill, get them walking. After a little warm up, we take their heart rate. If they're at 110, what do? Either increase the speed or incline on a treadmill. That's the other way to increase the intensity. If they're at 170, what do? Back it down, right? Back it down because it's now too much, right? So we're too intense, and when it's too intense, we're not going to have the sustained effects. We're going to fatigue too quickly. So do that to figure out your target heart rate range. 220 minus your age. Multiply that number by 60%, multiply that, and then your max heart rate by 80%. Figure out what your range is. Is your 20? Because that way you don't have to do anything, or you just got it all in your head. You're not doing any math right now, eh? All right, everybody come up with their target heart rate range. So pretty simple. That is what I'll expect of you for any written exams, is knowing 220 minus your age and then 60-80% of that. Now, things can get a little bit more complicated. For our patients who are older, these simple formulas aren't quite as accurate. Also, if my patient's heart rate, if their resting heart rate, if my patient's an older adult and their resting heart rate is 98 beats per minute, boy, if my patient's 85, once I do all this formula, I might have to say, geez, just sitting here, you're working out too hard. Well, that's not the truth, right? That's errors within the formulas that we're using. So again, for our class, 220 minus your age, 60-80%, that's what I need you to know. For your patients who are older, increased resting heart rate, or in different settings, they'll have different formulas. One example is this called the Carbonian method, multiplying heart rate max times intensity. Oh, that's the simple formula. Sorry. There is a different formula. I guess I eliminated it. Yeah, I eliminated it. So there's other formulas where you take the resting heart rate plus their age, and it just factor into that formula. So you might see those in other sources. You'll probably see that in PTA 3 as well. Other ways we can measure exertion. So I love the heart rate because it's just cut and dry. Problem is, there are some medications that limit the heart rate's response to exercise. Some medications and even pacemakers say this heart will not change. This heart rate won't change. That doesn't mean exercise isn't beneficial for that person, but we can't measure it in the typical way that we would other people. So we have this other thing called the Borg scale. It's used to try to objectively measure how difficult an activity is for an individual. It's originally a 60-20 scale that closely represents expected heart rate. The modified Borg, somebody came along and said, my patients don't understand 6-20, so we're going to make it 0-10. All right. The great thing about the original Borg, 6-20, is if you want your patient to exercise at what's the low end of norm for heart rate? 60 beats per minute. And then what's close to, for 20-year-olds, what's heart rate max? 200. So the Borg scale is so easy. If you want your patient to exercise at 130 beats per minute, it equates to a 13 on the Borg. It's just all they did is they took the last zero and lopped it off and said, oh, give me a rating. And I'll tell you what, for most people, it really correlates with their heart rate. It's really incredible. So if we're going to use the Borg, we want to exercise somewhere between 11 and 14 out of 20 on the original Borg. for close to 20 to 30 minutes if they have a reason why we can't use our heart rate as that measure. So here's a couple of charts for it. Here's what the original Borg will look like. Here's the modified Borg. So to use these, we would have it printed out on a piece of paper, have it on our phone screen, have it on our iPads or whatever work computers we're using. And we get to say, okay, patient, looking at this original Borg, 6 means no exertion at all. 20 is maximal exertion. And there's some words, because again, it's kind of an abstract thing to ask our patients, right? How hard are you working, or how much exertion are you feeling right now? So it gives us some words, and we at rest, understand the tool, learn the tool. What do you think? And they say, oh, I'm at a 7. Okay, great. Then we get to start doing exercise. Now, once they have familiarized themselves with the tool, we get to use it during exercise. We get to use it during walking on the treadmill, riding, jumping jacks. I don't care what you do for a cardiovascular exercise. We could use it at the same time. But we have to get the at-rest measure first. And then here's the modified on the other side. Do we have one of these printed out somewhere? Yeah. So we have some other cardiovascular tests we could use. 2-minute step test. And tape, do you have tape? Any sort of
What do you mean?
tape to just stick to the wall? Yeah, painter's tape or anything like that. All right, there we go. Here's the Borg scales. Look at this giant big bind. Do we have any Borg scales? No, it's probably in the Borg scale binder. But yeah, here it is. I mean, all it is we grab the sheet here and we just say, okay, patient, where do you think you are right on this scale? And that's how we use it. Yeah. Yep. So that's pretty cool. We'll be able to use those in just a little bit. All right, 2-minute step tests. So again, we try to be objective with all of our measures. We try to make sure we can measure for progress, signs of improvement, safety. So the 2-minute step test, what we're going to do is have you guys ever participated in cardiovascular testing? Yeah. Undergrad degree, is that?
No. How do we call it? So.
Oh, okay. A little bomb for us to drop us on. All right. Interesting. So you've had a bunch of tests for cardio. Yeah. All right. So, and that's a measure of how good the heart is working and how the cardiovascular fitness for it. Anybody ever do maybe in phys ed class at some point, you do the mile run or the pacer run? There's a few different versions of those, which era we're talking about, but yeah, we've all done that, right? So we've all done some sort of form of cardiovascular testing. How much time does it take you to run 1 mile is a cardiovascular test. And if it took 12 minutes the first time you did it, went through a training program for 6 weeks, then we retested, say, wow, you could run a mile in 8 minutes now, right? So that is the measure of progress. So we have a couple other tests for our patients. Marking the wall midway, thank you, Tony, between patients' iliac crests and popliteal space. So we could take a tape measure and measure that. For our purposes in here, we can just eyeball it. That's okay, to make that a little faster. So midway, mark it on the wall. Perfect. It's a little high for me, but that's all right. Then what we're going to instruct our patient to do is march in place, raising their knees to the height of that mark on the wall. Right, that gives that visual of how high should they doing it. Right, this doesn't count. They don't have to go way high. It just kind of standardizes how much clearance that person is trying to get. And we're going to do it for 2 minutes. That's it. How many people have 2 minutes to do a test? No, I like tests that are short, and 2 minutes is a heck of a lot better than 3. So yeah, we'll do it. Can take as many rest breaks as we needed. Can use any sort of external support for balance if they need to lean on that wall. We can. If you can do 3 reps and need a break, and you want to do 3 more after a break, great. It doesn't matter. How long does this test last for? 2 minutes. And if they wanted to rest for 1 minute and 59 seconds of it, great. The test still lasts for 2 minutes. Time starts when the right knee is raised and ends at 2 minutes. So that's when we say go, and you press time on your timer right when that right knee is raised. Examiner counts the number of times the right knee reaches the mark, and then we get to remeasure the vitals after that. There are norms associated with it. I didn't put norms associated with it, but what's great about norms is the next one is a little bit better with it. We get to compare our patients' data with similar people, just like we do with range of motion testing, right? We have norms associated with range of motion testing. Shoulder flexion should be 180 degrees. You're at 150. You're 30 degrees off of norm, right? So that's one way we get to use all of these tests for not only patient progress, but also comparison to other people. And we also have the 6-minute walk test. 6-minute walk test, what's great about the 6-minute walk test, it's one of the most widely researched cardiovascular tests that we have available to us. It's a 30-meter straight course, clearly marked start and end, with chairs throughout the course for rest breaks. We're going to record our resting vitals and RPE. What's RPE again? Rating of perceived exertion. That's the Borg scale. So I use those terms interchangeably, Borg versus RPE. So make sure we know that. Patient tells the therapist then tells the patient, we're going to walk for 6 minutes. You're just going to walk laps back and forth. You can take a break anytime you want. You can sit, you can stand. We're just going to walk as far as you can for 6 minutes up and down this course. You can use any sort of assistive device you want. If they use a walker, great. Let's grab the walker and do this test. Sit down for breaks, doesn't matter. But the therapist is going to record all of that data. What I love about the normative data is that because this is so widely researched, you can break down the data for age, gender, disease. There's for a 50-year-old male with Parkinson's, their 6-minute walk distance should be 400 meters. Like that, we have that amount of data to us. So if you have a 50-year-old with Parkinson's, you get to say, listen, you should be walking around 400 meters and you're only at 300. We have to really work on this now. So that is one of the best things we have for this, because it can be tough to tell someone with, we shouldn't be comparing someone with certain diseases to people without those diseases, right? So because we're not comparing apples to apples at that point. Now, if I'm doing my test and I'm saying, okay, keep going. And if I'm just lackluster, but you've got somebody like Danica who's excited, happy, pleasant to be around, whose patient's going to work further? Right? Why? They're motivated, right? So, because she's fine. I want to do well for her. Did anybody care about me? No, nobody cares. So, we should be encouraging our patient along the way. That can influence the test. I won't expect you to know this, but the American Thoracic Society has a protocol on what specific words of encouragement at what times to use. At 2 minutes, say good job. At 3 minutes, say keep going. At 4 minutes, say I'm proud of you. Whatever. I don't know what it says, but so my rules for you is to be encouraging. Don't just be me and just say, okay, I'm writing it down. Don't worry. Be encouraging throughout it. We're going to measure the RPE throughout the test, and vitals after. And to document, the number one thing we need to record is total distance. That's the number one thing we're going to record. We're also going to write what rest breaks do they need and how long do they need it for, what assistive devices used, and what RPE. The great thing about this, right? So what is our whole job? Our whole job is to measure something and look for signs of progress. If I only write distance on the 6-minute walk test, how many ways can I measure that patient's progress? Just one. They either walk further or not. if I write distance, how many rest breaks and how long they lasted for, which assisted devices they used, and their RPE throughout the test, how many ways can I now measure progress? 1, 2, 3, 4, 4 or 5, right? If someone goes from using a walker, rolling walker, to a straight cane, what do you think is going to happen to the 6-minute walk distance? Potentially, it could potentially go down because we're taking away some balance. Patient has to walk a little slower to maintain their balance. So is that progress for the patient though? Right, moving from a walker to a straight cane is going to increase their independence. Now they can carry a cup of coffee as they walk in the apartment rather than how do I get from my kitchen to my recliner. So we are making progress despite the distance going down. So we get to talk about that in what section of the SOAP note? In the assessment section, we could talk about that, but in our objective, we keep the data. But if we don't document that data, we can't discuss how, even though this number is different than we would expect, it is progress. Does that make sense to everybody? So, what I want to do now is I want you to do, we got an hour. I'll tell you what, I'm going to finish lecturing and we'll practice at least one of these 2 tests for today. Okay. So other general health tests we could take is BMI. BMI, I think at this point, everybody in this room knows the faults of BMI. I think it's pretty good for populations, lots of people. I think for individuals, it gets wonky really quick. But it is a measure we could use. Okay, you have my support. Something else we could do, especially if in combination of BMI, is waist circumference. So for a certain height, what is the waist circumference should it be? And especially if we use BMI with waist circumference, it kind of gives us a clue as to how that person is overall health if we use both of those measures. So, you know, we're going to be exercising with, gosh, 99% of our patients are going to have some sort of form of exercise. There's going to be the rare exceptions, but so we should be taking vitals at rest to make sure they're safe to exercise that day. And this sentence doesn't make sense to me. Vitals should be taken during vitals. What does that? I think I mean during exercise. Vitals should be taken during exercise, but sometimes we can't. If we're running on a treadmill, how easy do you think it's going to be to take somebody's blood pressure? It's going to be really difficult for us. There's some equipment that we could use for us. So in some settings, we might have a better shot at that. But here's what we get to do. At the immediate cessation of exercise, the first minute after exercise, collect that data. That data counts as during exercise vitals. So if we did a 2-minute step test and we said, okay, sit down, we immediately took their vitals, I would be able to count that as during exercise vitals, because it takes roughly 3 to 5 minutes for our vitals to return to resting state after exercise. So what I would do with my patients is at rest. What's the major reason to take it at rest? Safety. Can we exercise today or not? I have them do an exercise or a test. The first 30 to 60 seconds after that exercise or test, I take their vitals again. I document that as during exercise, and then I wait 3 to 5 minutes and check it one more time. Why do I have to check it 3 to 5 minutes after one more time? What is the importance of that? Make sure everything goes back to where it was, right? So if I'm exercising in home with grandma and I say, wow, grandma, we really did a great job today, I gotta run. You guys happy with if I leave grandma's heart rate at 130 beats per minute? Something could happen to her, right? So I've got to wait and make sure they go back to their normal resting levels. If not, we have a problem. So What should happen with our vitals with exercise? Well, heart rate and respiratory rate should increase in relation to exercise. Rhythm should be unchanged. We shouldn't all of a sudden get some sort of abnormal rhythm, right? It can be faster rhythm, but it shouldn't go from normal rhythm to skipping beats and double beats, right? So the rhythm should be the same, just faster. Systolic blood pressure should increase in relation to intensity of exercise. Diastolic, I have a couple of different textbooks say different things, should raise no more than 10 to 15 millimeters of mercury. I always think of 10. One textbook said up to 15. So this textbook says 10 to 15. Fine, we'll say that. Clinically speaking, if it's more than 10, you should be stopping exercise. SpO2 can change depending on diagnosis of fitness levels, but we should be staying over 90% as we're exercising. All right, don't exercise if systolic blood pressure is over 180 millimeters of mercury at rest or below 80 millimeters of mercury. If diastolic blood pressure is over 110 at rest. This is an interesting one. If the pulse pressure, which is the difference between the top number and the bottom number, is less than 20 millimeters of mercury. That's an interesting one. I don't think I've ever seen that clinically. Have you ever seen that, Tone? Yeah. In PTA 3, is that what you mean? Oh, yeah. Yep. If the resting heart rate is greater than 130 beats per minute or less than 40 beats per minute, SpO2, I think this is the third time we've seen this, less than 90%, or if the respiratory rate is greater than 35 breaths per minute. So those are don't exercise if. We would stop exercise if we start seeing an abnormal response for any of these. So during, resting vitals, we look at this here. If we meet all this criteria, great, we can start exercising. During exercise, if we notice any of these things happening or not happening, I should say. So if the heart rate and respiratory rate all of a sudden shoots up, even though we're started just introducing exercise, it should increase in relation to the intensity. If we're doing low intensity, but we have a drastic response, it doesn't make sense. Or if the opposite happens, if heart rate and respiratory rate plummets, even though we start increasing intensity. Same thing for blood pressure. All right, so we have the last thing I'll show you is just different factors that influence vitals. Everything from time of day, age, environment, infection, physical activity level, emotions, medications, site of measurement, sex, male versus female, and other category too. So some pretty interesting stuff for us to just show how the vitals can just vary for a whole host of reasons. So that's one of the reasons why when we take somebody's blood pressure and it's high right now, anybody had a high reading the day one that we did this? I think that was day one. We would never say, oh, you got to get that checked out. It's just one measure, and how many different things affect our vitals. Everything from did you take in coffee or are you excited right now? So something to educate our patients on. All right, so here's what I want to try. I want to try using the Borg scale at rest, during an exercise, and then at the completion of exercise. And if we can, we've got 50 minutes. So what I'd like is all of the vitals. I know we just practiced. Let's get the Borg, and then let's do one of the two cardiovascular tests, 2-minute step test or the 6-minute walk test. And then at the first moment that you stop that test, take those vitals again. And that counts as during exercise. Okay? Everybody know what we're doing? All right. Let's play.